Imagine if you could easily find solutions to make your region or city smarter, greener, better connected, more social, and closer to citizens. The Interreg Europe Policy Learning Platform can help you access knowledge about the latest policy trends, discover expert-validated good practices from all over Europe, find solutions in our peer review, get tailored support from our expert team. We can connect you with the right people and organizations. Together, we will find ways to solve your region's or city's challenges. Start your policy learning journey today.
Good morning, everyone. Welcome to this workshop on resilient healthcare in rural areas. My name is Erik Gløersen. I will be facilitating this workshop together with Mart Veliste. We are both policy officers at the Interreg Europe Policy Learning Platform, covering the social Europe dimension. We're also joined this morning by Vladimir, who's a communication officer, and he will start by just a few then elements on how this will be organized technically and concretely. Vladimir, please.
Good morning, everyone. Happy to have you on board for this webinar on resilient healthcare in rural areas. My name is Vladimir. I am the communication officer, and here are just some rules about some general rules about the webinar. So the webinar is actually being recorded, and it will be shared together with the presentations and key learnings in the days following today, and you'll receive it as well automatically via email. If you want to ask questions to the panelists, please use the chat box below to ask them, and our experts, Erik and Mart, will be raising them after the presentations. Also, at the end, you will have an automatic survey popping up. So please take time after the recording ends, the webinar ends, to fulfill it. So, and now I'm handing over back to Erik. Thank you.
Thank you, Vladimir. This topic of resilient healthcare in rural areas is high on the political agenda, as many Europeans are worried about what they perceive as an erosion of health service provision in their areas. This not only affects quality of life, it can also be an actual bottleneck for development of many rural areas. This is a challenge which has been identified by the European Commission. We'll hear more about that in just a few minutes. And also the OECD has produced concrete recommendations on how it can be addressed, with possible solutions such as reinforcing primary and integrated healthcare, establishing more multidisciplinary health centers, and expanding the use of telemedicine. So what we'd like really today is to discuss how such solutions and others can be implemented on the ground, and also hearing about the potentials of the solutions and maybe the limits, considering concrete acute challenges such as the shortages of health professionals in many areas, and of course the challenge of aging, which we see in the years to come. Challenges may be even more important in these rural areas. To address these challenges, I am joined today by a number of very inspiring and well-informed speakers. We will have first a keynote speech by Patricia Martinez of the Ruralt Pact Support Office. I will let Patricia explain to you what this is and how it's becoming a key platform for integrated policies targeting rural areas at the European level, and also with ambitions of how to promoting local and regional implementation of more integrated rural development policies. This will be followed by Dr. Veronika Rasic, who's the founder of the Ruralt Health Compass and an executive member of EURIPA, which is the European Rural and Isolated Practitioners Association. We'll then move on to two presentations of concrete good practices in European regions. One from the NEAR project, which is about integrated solutions for health provision in the Navarra region of Spain. And a second good practice presented by Juliette Vas from the Gérontopôle Nouvelle-Aquitaine in France about dental healthcare in rural homes for elderly people. But first, I would like then to ask Patricia to present at this Rural Pact Support Office first, and what they have been doing and how they have been addressing rural health challenges. Patricia, please.
Good morning, everybody, and thank you, Erik. I will share my screen. Yes, come in a second so that I can indeed tell you what is the Rural Pact, the Rural Pact Support Office, and where does health fit in this rural vision, this policy at EU level. It all started with this long-term vision for EU rural areas. This is a communication from the Commission created in 2021, and it brought together already different commissioners for democracy, demography, agriculture, including rural development, cohesion, and reformed. And to highlight this cross-policy document, it looks at all aspects of rural life, and it puts the citizens of rural areas at the center. After consulting hundreds of actors across Europe to develop this long-term vision, the Commission set 10 shared goals on how they express the common aspiration of the Europeans, how they would like the rural areas to be by 2040. These are very heterogeneous, very ambitious. It highlights the importance of cross-department cooperation. And within these 10 goals, the one that is very important for today's webinar is Goal 9, which is highlight that rural areas need to be equipped with efficient, accessible, and affordable public and private services. And this includes tailored solutions such as healthcare and long-term care. To achieve those 10 goals, the Commission put an action plan, a rural action plan in place, and this plan has 9 flagship initiatives. The novelty here for this plan is that it brings together many different Commission departments, and the Commission organizes the coordination across them. Several of these flagships are relevant for healthcare, but to highlight number 8, social resilience and women in rural areas, under which the Commission adopted the European Care Strategy in 2022. But also many others. Many other initiatives are relevant for healthcare, and for instance, we find some research project to tackle medical deserts, the identification of mobility, which is very important for the patients in rural areas and for the healthcare professional, investment in digital skills and infrastructure, or in social economy. That has been proved that is very important, especially for care in rural areas. This action plan has also actions, so to implement them and to improve governance for rural areas. And one of those is to propose this Rural Pact. And what is a Rural Pact? Is a formal space and a framework to boost cooperation among all stakeholders that are working away on another for rural development to act towards the shared goals of this vision and 3 key objectives. Bring up the voices of rural people higher in the policy agendas and get them acted upon, to promote networking, cooperation, collaboration, and mutual learning, and to encourage commitments to act to contribute to achieve this rural vision. At the moment, the community is over 2,500 people from many different countries, EU and non-EU, from many different organizations, also individuals. And what is important to highlight here is that this for this movement to happen and for those interested to be to join and to be informed, it's important to register, and you will be receiving the link to this if you wish to do so. What we do at the Rural Pact Support Office is to implement the networking activities of this Rural Pact. So we identify and promote good practices. We organize different type of events, physicals, online, high policy events, and we keep the community informed through different channels and publications. And last but not least, what is more important for this webinar is that I wanted to share with you what were the main points stressed in a webinar we organized November last year about access to health services In rural areas, we have 70 individuals from over 20 countries. What were those key aspects regarding enhancing healthcare? So first of all, to ensure attraction and retention of health workers in rural areas. Participants stress that we need to adjust the curriculum for healthcare studies so that they better consider the specific context of rural areas. We also spoke about training options in rural settings. They have demonstrated to have positive outcomes, and therefore it would be important that they are replicated in other territories. We also need to make sure that it is possible for the healthcare professional in rural areas to have access to ongoing training and to skill development so that they can continue developing their careers throughout their life. And this should focus not only on the specific clinical skills, but also alternative learning methods. They need to include decentralized models so that they are accessible. And also to look at technological proficiency so that we avoid the digital divide. This leads me to the second part, let's say, innovative ways to deliver health services, innovative solutions. We said that innovative solutions need to be integrated. They need to take into account what is the workload of the professional, what are their skills, and also to look at the long-term viability of these new innovative solutions. We spoke a lot about telemedicine solutions. Participants stress that they need to be designed in a collaborative manner. This means involving all those that are going to implement and to benefit from those telemedicine solutions. So this is the healthcare practitioners, but also the patients, and to collaborate with the IT developers so that together they all understand what are the needs. For this, we also spoke about specific regulations because we understood there is still a lot of policy gaps in several countries. So specific regulations, supportive conditions are necessary to facilitate telemedicine, mobile health units, and community-based practices. And this regulation needs to address existing legal barriers, privacy concerns, healthcare standards so that they have the trust of the patients. And lastly, and I know that Veronika will elaborate more on all this in a minute, we also stress the need for well-proofing all these specific regulations. So again, to look at them through the lens of rural areas and unified political support. So cooperation across all the public administration department, not only rural development, not only health, but all together, and also involving other departments such as, for instance, education, so that all actors and all departments support together on this. I finish here and I remain at your disposal for further questions and information.
Thank you very much, Patricia. I think this is very important, highlighting these elements, that there is a community being built up of rural stakeholders that are really concerned by this. And this community is something you can join on the Rural Pact Support Office website. So you can go and look up there and meet this community, interact with them. There are platforms where you can look for people to get inspiration. This can also very easily be combined by the Interreg Europe community, which most of you are already part of. And which has other types of service offers in terms of organizing workshops, meetings, all kinds of services, with Mart will present at the end of this webinar. So combining these, and also then having the synthesis of how important this is for EU level institutions, the Commission and others, pushing for this, and this getting more aware of this policy momentum in favor of better health service provision at the EU level is something that can help promote this agenda also at the regional and national levels. So I think it's important to get this framework and see how many instruments you can mobilize, and that it can also help to find funding sources through these different channels. This is something we'll get back to, but now I would invite to move on to Veronika, who will maybe going back more concretely, what's going on within these rural areas, what are the challenges, and what are the possible solutions that you see emerging, maybe from a more local and regional perspective, from the practitioner's perspective also. Veronika, please.
I'm having some issues with my microphone, but here we go. Thank you all. It's a pleasure to be with you today. I'm just going to try and... can you all see my presentation at the moment? Okay. So My name is Dr. Veronika Rasic, and I will be presenting very briefly about the challenges and opportunities within rural health in Europe. So I will focus briefly on these 4 areas. So the rural health workforce, rural health training, infrastructure for rural health, and finally, rural proofing and rural policy. So the WHO Director General, Dr. Tedros, rightly said, there's no health without healthcare workers. And the rural health workforce is one of the biggest challenges and opportunities that we face when trying to build a resilient healthcare system. In rural communities, the primary healthcare team is at the heart of the community and at the heart of healthcare provision for rural areas. Rural practice is multifaceted and community-oriented, and rural healthcare workers are a valuable resource for communities. They enable people to live healthy and productive lives in their local areas. The primary healthcare team is an interdisciplinary team, which means that it includes doctors, nurses, and other allied health professionals. Each bring their own unique skill set, and they work together to maintain the health and well-being of rural communities. The realities of rural practice require healthcare professionals to develop a generalist skill set and practice to the top of their scope, as they are often located far from hospitals or other healthcare providers, and they often have fewer resources at their disposal. The rural healthcare workforce must be fit for purpose, and this means that they have the required skills and expertise to meet the needs of the communities that they serve. People are central to healthcare, and this is important to recognize when we're looking at digital technologies. We should not be looking to replace people with digital technologies. However, if done right, digital technologies can support healthcare systems. So what are some of the challenges when thinking about the rural health workforce? The first and most obvious is recruitment and retention, and it can be difficult for rural communities to attract and retain healthcare workers, and there are many factors that contribute to this. Healthcare workers have many of the same considerations when they're considering a new job. Is there adequate childcare, schools? Are there good transport networks? Is there housing available? What's the digital infrastructure like? Is there opportunities for career development, and is there support available for them in that area? Workloads have also become an increasing challenge, becoming more difficult to manage as the numbers of patients and the complexity of those patients increase, particularly when we look at the elderly population who have greater healthcare needs, and often there's a higher percentage of elderly people living in rural areas in Europe. These increasing workloads have also led to burnout, with existing staff often leaving, and then with the result of more pressure being put on those who decide to remain in rural areas. Medical deserts are a term used to describe areas that do not have adequate healthcare, and this can be in regard to demand or supply of healthcare, which includes the lack of services, inadequate access, and situations where healthcare quality is poor. The number of medical deserts in Europe is expected to grow over the next 10 years, with approximately 40% of the current healthcare workforce due to retire. And that's not just in rural areas, but the overall healthcare workforce. The OASIS project has done work on establishing ways to measure and address medical deserts, and I would recommend that you have a look at their findings and the work that they've done. There has been an ongoing lack of investment in rural infrastructure for health in terms of healthcare facilities, appropriate equipment, and training. And again, I'd like to briefly reflect on the digital health technologies, which could be used to reduce things like the workload burden, particularly in areas such as electronic health records, monitoring of chronic conditions, and the reduction of bureaucracy. However, we must not overlook the importance of developing digital literacy, both in the population and the healthcare workforce. The development of digital health tools must also include, as Patricia mentioned, collaboration with healthcare professionals and patients, and a common barrier in terms of infrastructure that will need to be addressed is, of course, the access to mobile data and broadband in rural and remote areas. These challenges within primary healthcare are not only seen in rural areas, but they are also being experienced at the wider national levels. This slide shows a summary of the results of a survey conducted by the Wonka Europe Working Party for Policy Advocacy, which represents the views of family doctors in Europe. The main challenge that was highlighted was the lack of family doctors. This was followed by the workload pressures, infrastructure, and financing of primary care. This is not just a rural issue. However, it is often felt most acutely in rural areas and can result in much poorer health outcomes for these populations. To address the challenges facing rural health in Europe, we need to look at how we provide training to the future rural health workforce. You can't be what you can't see, is the popular saying. There have been many research studies looking at the factors that influence student and clinician choice to work in rural areas. The findings of this research could be summarized into Grow Your Own. This means that we need to be looking to recruit students with rural backgrounds and provide opportunities for early exposure to rural health and rural practice. One way that this has been approached is through longitudinal rural clinical placements. This allows students and young healthcare professionals to be fully immersed in a rural community over a longer period of time, often for a few months or even up to a year, while receiving support and mentorship from an experienced rural clinician. Why is this important? Because the majority of medical education happens in urban-based universities with a heavy focus on hospital-based specialties during undergraduate training. This is a time when students form their ideas about what kind of clinician they want to be. This is they often have limited exposure to primary healthcare and often no exposure at all to rural healthcare settings. Primary healthcare has been identified by the WHO as essential to reaching the goal of universal health coverage. However, at present, our medical education systems do not reflect this. To help address the growing challenge for rural health, we should consider developing rural training pathways, starting from undergraduate training and extending to postgraduate training and continuing professional development. This would require investment in the development of things like rural academic networks, which is something that EUREPA is currently trying to develop within Europe. Good quality rural health teachers and mentors are also an important part of nurturing the future rural health workforce. They serve as role models and help to support students and early career clinicians as they navigate the challenges of working in rural health. This is particularly important during the first 5 years of clinical practice, and it's also an integral part of developing a strong base for rural research and academic activity, which can support evidence-based decision-making for health system strengthening. We need to do more to identify, recognize, and value rural expertise. These clinicians can be good partners for local and regional authorities looking to develop their rural health capacities. The rural health community is also a teacher. Students and clinicians learn so much from the communities that they serve. It is important to see the community as a partner in developing rural training pathways, as this can be a way to ensure sustainable provision of healthcare and rural medical education. Rural health scenarios, and rural placements should be included in the medical curriculum in all countries, as all countries in Europe have rural populations, and students need to receive training and exposure to these groups so that they feel empowered and proud to choose a rural health career. Rural infrastructure can often be inadequate, as was mentioned earlier. Investment in infrastructure is not only important for healthcare provision, but it is also vital for social cohesion, job creation, and revitalization of rural areas. Access to other services also contributes to health and well-being of rural people and rural communities, and we should consider the social determinants of health in rural areas. These factors can account for between 30 to 50% of health outcomes. So briefly on rural proofing. Rural proofing is a term that is used to describe the use of a rural lens when assessing policies and programs to ensure that they are adequately accounting for the needs, opportunities, and context of rural areas. Rural proofing for health encourages us to think rural when developing, monitoring, and evaluating policies and programs which are being applied in the rural context. 1 in 4 people in the European Union live in rural areas. And some of the things that we should be asking are, does this consider the rural context? Does this meet the needs of the rural people and communities? Does this have the desired outcome in rural areas? Additionally, a cross-sector collaboration should be encouraged, as health and well-being is cross-cutting and not solely the responsibility of the health sector or health ministries. Rural proofing for health is a global imperative, and this image is from the OECD and WHO joint work on this topic. It clearly depicts the importance of both strengthening rural health systems and working across sectors on the determinants of health. At the end of my talk, I wanted to briefly mention EUREPA. the European Rural and Isolated Practitioner Association. This is a unique body that represents rural family doctors and primary care clinicians in Europe. And EUREPA hold an annual Rural Health Forum. This year, it will be held in Lincoln later on this month from June 20th to 22nd. And EUREPA has also published a blueprint for rural practice in Europe, which you can find on the EUREPA website. I would also encourage you to have a look at the WHO guideline on rural health workforce development. These documents will provide a good overview of the challenges and recommend possible solutions for the challenges that we face. Thank you very much, and I look forward to the discussion later on.
Thank you very much, Veronika. I think this is very interesting to see how you describe being a doctor, basically a medical practitioner in rural areas, maybe something quite different, because you are responsible in a way, more responsible, you are really integrated in a community, the distance to the hospital is greater, you have few people to work with, all that this creates a specific context. And as you say, this can be a factor of pride, but then you need some recognition and visibility of what you're doing. So that's very interesting to see. And also the way you describe health policy as something that needs to be integrated, basically also because doctors will come if there is childcare, basic services are in place. And as you said, also because a lot of health, health can be determined by local context, and then you need an integrated policy for that. So all of that is, I think, is very interesting to see it integrated and see how it becomes it should inform policy making. You mentioned you had one interesting slide on the hot topics, and what I would like to ask now is our participants if they what do they consider in their home region or their home country as the key hot topics rural health. If Vladimir can help us putting up, we had a short survey, so if you can maybe type in some keywords on hot topics in your country, and then we can see them emerging jointly. So if all participants are invited then to put in a few keywords on the hot topics for rural healthcare in their home country or region. Leave a few minutes, reflections, whether those that were already mentioned or quite other ones that you think are particularly important. I think we can close now. Vladimir, if you can, we can maybe see some results from the survey. Oh. Ah, 19, okay, no. Access to family doctors, lack of medical staff, all the equipment, infrastructure also, multidisciplinary, organizing multidisciplinary activities, recruitment, as was also mentioned during the presentation. Accessibility is also, so then distance to the closest health practitioners, health insurance also, so people that are basically having difficulties accessing insurance. Yes, medical deserts, of course, as the output of many other, there again from Sweden, the notion of the workforce access. And then, yes, vicious circles in Spain of this, the more you have population decline, the more health services are difficult to operate. So basically, communities going beyond this threshold where it gets very difficult to organize but I see workforce then coming back again and again. So that basically, as you said, this is a general challenge for all of Europe, but it becomes more acute in many rural areas. And lack of doctors and closing. Veronika or Patricia, would you like to comment on this list of your reflections, seeing this, the observations from what is mentioned by our participants?
I think I'd just say that it's quite well established at this point that we're all facing quite similar issues. What's not so clear is what would be the best way forward and how to address all of these issues and where the investment would come from, because we really do need investment in these areas to be able to move things forward.
And then when you say investment, could you elaborate a bit further on what kind of investment you see as key then?
So I think that there definitely needs to be a cross-sectoral approach, which was mentioned. So we need to look at the infrastructure of the community. So does the community have good roads? Does it have, good public buildings where the healthcare is happening? Is there schools available to, maintain young families in the area? Are there job opportunities? Because if you want to recruit a medical professional, they often will come with their family and their partners who will also need to look for work. And if there's no work for them in the area, that will mean they choose not to go there. So the investment needs to come from lots of different angles. In healthcare more specifically, I'm biased, but I'd like to see more investment in primary care as a whole at a national and regional level. And, it has been shown that for every kind of, let's say, euro that you would invest into primary healthcare, the return is 14 euros. So it's definitely worth investing, and the research has been done, the evidence is there. It's just about getting all the partners on board to understand why this is an important issue and area to invest in.
Mm-hmm. I saw from your presentation, you of course, we see the demography of the workforce of 40% retiring, I think you mentioned, maybe even more in many of the rural areas. This requires some long-term thinking, and you can of course say, why didn't we think of this 10, 15 years ago? Because we knew it was coming, but we're still somehow surprised all the time that this is. So the idea now is to try to start really setting up measures that will have effect, even if they only generate effect in 10 times, but we kept not being sufficiently concerned about the demography.
I agree, and I think this is a question of health workforce planning at a wider national scale, but also thinking about rural health and what kind of rural health strategies we might need, and how would we then shift some of the workforce capacity more towards rural health and rural areas, and whether, as I was mentioning, that requires a shift in the kind of training that we provide. There's often not enough exposure during undergraduate training to primary care, let alone rural practice. So I think that kind of shift within the medical education system also needs to happen for us to see different profiles of healthcare workers in the next 10 years. It's also important to mention, we've gone through a pandemic. There's been a lot of fallout from that. That's definitely impacted the health workforce. Many are feeling quite burnt out. They're choosing not to work in the healthcare sector anymore. And that kind of thing also needs to be addressed, the morale of the workforce and the prospects that they see with staying in the healthcare sector.
Have you still seen, part of your work or your REPA more generally, have you seen good examples of how this concretely can be done? The types of measures you just mentioned, does it exist or is it to be invented?
So I think there's good examples in small local areas where they've taken initiative. Some countries also have more national programs, training programs, for example. I know here in the UK, Scotland has a rural training pathway that's postgraduate, and in Wales, some of the universities have undergraduate rural focused training pathways, but it's not across the whole country. And in most of Europe, there isn't any kind of rural focused medical education. So this is something that definitely needs to be looked at and just introduced into the medical curriculum as a subject, possibly. And looking further at how that then integrates into other stages of training.
Thank you. I would remind all workshop participants, you're very welcome to submit questions in the chat if you have any around their own presentation. Veronika is very knowledgeable from her network activities across Europe of what goes on, so please feel free to submit your questions. I had another one on rural proofing. I think this is a very interesting concept. I always get a bit, when I hear about this, a bit confused. Okay, sounds like as a principle. How is it implied? How would it be applied in practice? Do you have any examples concretely of what kind of, is it national policies, European policies? Concretely, what does it imply and how does it become beneficial? Is that possible?
Yeah, so again, the UK is one of the earlier adapters of rural proofing. They have officially provided guidance at a national level for rural proofing. As to then what actually happens in practice, that's a little bit more blurry. So there is a department that has been assigned to rural proofing, which is the Department, again, of Agriculture and Rural Affairs in the UK. And what should happen is this department should be looking at the policies that are coming through, and identifying ones that are not meeting the criteria, so that are not addressing the needs of rural communities, or, you know, emphasize actually this is overlooking rural communities. In practice, honestly, I'm not sure that happens in that way, and that's unfortunate. And I think in the countries where there is a rural proofing guideline, it's shown to be difficult to actually then concretely do the rural proofing. Sometimes it's because there's so many policies coming through, and that department hasn't been assigned perhaps enough capacity to process all of these new policies coming through. And the rural proofing often isn't looked at the beginning, which might be making the process more difficult. So when we are already beginning to think about developing a policy, that's when we need to bring in that rural perspective and decide, is it actually addressing the needs that the rural communities have? And in addition, when we do recognize that a policy isn't working in a rural area, we need a process to then decide, well, what do we do with that policy? Do we have to develop something different for rural communities, or do we have to, you know, discontinue that particular policy and start from scratch? And I think in a political environment that can be very difficult for various reasons, and often the voice of rural communities is not heard as much in, you know, urban centers where most of these decisions are being made. So that can be part of that challenge as well.
Thank you. Patricia, you posted a link now. I know the Rural Pact is working actively on rural proofing. Maybe you would like to say a few words on how you try to make it operational and effective.
Yes, actually, this is coming from the ENRD, it's the European Network for Rural Development, and they had a specific group working on rural proofing. So I put the link. There's also some trainings and some guiding documents that were elaborated by a number of people, also with the Commission. And the Commission has been including this within their own regulations to apply this and to try to lead by example, which, as Veronika said, is not always easy. And now they're trying to push that this happen also at national and regional level. And I think one of the key aspects what Veronika said is that this needs to be done at the very beginning, not at the end. It needs flexibility in terms of policy formulation. And to add another layer of complication is also the fact that rural areas are not also homogeneous. You also have like rural areas that are closer to urban settings or more outmost, mountainous, etc. For instance, for mountainous areas, so there are a large number of good practices that are bringing health services, but they're very particular. They have very particular characteristics. So this is really to consider also all these layers of characteristics of rural areas when designing the policies. And they need also a lot of training for those policymakers that are designing the policies to at least to consider this. So I invite them to have a look at these resources for the ENRD, because they have some guidelines, some checklists, at least to have this reflection when you are designing the policies. And again, cross-department cooperation, because it really, we are speaking about the healthcare workforce. There are people, and as Veronika said, there need to be an attractiveness of the area for them to move there. And this is not only the health department alone, it's really across department cooperation.
I know the Rural Pact Support Office and more generally the long-term vision builds a lot on integrated strategies, and then integrating health in, or including health in these integrated strategies is a big component. Would you like to elaborate a bit on how you approach these integrated approaches to rural development and positioning health in those?
Yes, it's at the core of the Rural Pact, really. And as you said, perhaps coming a bit late in the play, but normally we have been looking at rural development through the angles of agriculture. And agriculture for sure is a key economic sector. But to looking at the demographic trends and of rural areas, it was like brought to attention at very, very high level. We really need to make something that is integrated. We really need to bring all those that are working across departments, starting by the Commission. So every time that there is a topic, for instance, for this one, is the Department of Health with the Department of Rural Development and Agriculture, collaborating also with external actors like WHO to have this integrated approach and looking at how the different components, and even if they might not have the competence, because at the EU level, for instance, of health is limited, is this a national competence, but at least to allow these exchanges and this identification of good practice and this push at national level so that they follow a similar approach, and give them examples of existing coordination mechanisms, for instance, that exist in other member states. And very recently we did a policy lab on that, on how everything that has been articulated in other countries can be replicated at national level, but also at local. And it goes back to these coordination mechanisms, to having representatives of rural areas in the decision-making processes at national and regional level, to have the end users, those that are going to benefit or to apply the solutions at the core of the designs of the policies. So it's the core of the Rural Pact, really to push for this integrated and cross cooperation.
Excellent. Thank you very much. This is a great transition to our next speakers from the Navarra region in Spain, who will be working about talking precisely about new integrated models for social health policies, and then also about cooperation between different departments. But you will have much more details about that. So Inés, please.
Sure. Good morning, everyone. Thanks for the invitation. We are going to share. Oh, it's okay?
Perfect, thank you.
Okay, so my name is Inés Fernandez, and she is Elena, is my partner and my colleague, and we work in the Integrated Social and Healthcare Program. She is the nurse, and I'm social worker. And for the program, it's important to show how we work together. This is a public government program located in some areas of Navarra. And so now we are going to explain how we perform our job. We are going to speak about the context of the program, the profiles, features of the program, and the teams and area resources.
So first of all, we are going to start with the context of the program. This program is the result of a collaboration between Social Services Department and Healthcare System to develop integrated common actions in Navarra. It starts in 2018 in the region of Tafalla and then extended 4 years later in 2022 to the areas of Estella and Tudela. It's planned to extend the program to the rest of Navarra, including the area of the Pyrenean villages and the capital, Pamplona. And why this collaboration? Well, because professionals usually work separately from each of the systems. However, people cannot be divided or separated by areas or dimensions. This is the challenge for the system to adapt to people and not for people to adapt to it, which is really our goal, our purpose, to implement the person-centered model of care. Next, after that, we will explain the profiles of the users or beneficiaries of our program. First of all, and of course, persons and families in rural areas of Tudela, Estella, and Tafalla, with complex social and health situations which need integrated actions from healthcare and social services systems, and people who need an intervention on critical situations during temporary periods of time. Afterwards, which are the features of the program, the model of care we developed is the person-centered model of care. With a customized attention, people choose how they want to live and how they want to be taken care. It is a set, people plus family plus environment. Next, the territory, rural areas. Services are close to people. There is a tailored attention focusing on the specific needs of each area. And the decentralized services. And finally, the objectives. improve their quality of life, recover their functional capacity, continue living in their homes, and prevent early institutionalizations. Then we're talking about the teams and the area resources.
Okay, for the program, this is the most important and interesting part. In each primary care area, social services and healthcare system working together. When they identify a person or a family with a complex situation, they design together an individual plan. A complex situation is when a person needs multi-care system because they have different problems. For example, different disease, or economic problems, or has no family. So when the situation can be attended by primary care area, maybe because there are not enough resources or this person needs other type of help, the social health coordination team attend this situation and we work integrated. At the same time, a hospital can identify a person which needs help in a specific moment. For example, a woman who gets hospitalized because she falls down and she is in a difficult moment with high needs, her sons or family during all day are working and she hasn't any help because she hasn't needed it before. So now in this situation, family need to make decisions and organize themselves. During this critical time, the social health coordination team visit them and make a plan with them. We can offer different resources to help them while they are looking for a final solution. The resources are in the area, in the territory, and in the central city. They are free, they have a limited duration, and they are specialized and the services are intensive. The access is easiest than community or regular resources, and we can say that resources are like a bridge that you need in a specific time or in a specific moment to find another way, because in that moment of crisis, you don't know what to do. So we have a home care team that professionals go home and help them with the day-to-day activities. We have a day care center during all mornings, and a nursing home, like it's 24 hours. So in both of them are different activities like cognitive development or functional recovery. They are doctors, psychotherapists, nurses. So professionals were integrated and make an individual attention plan with families and persons. And finally, the results of the program, we have a high satisfaction because people feel gratefully with the services, and family feel more supported in moment of crisis and critical times. People feel they can decide about their lives, and the system adapts to people and their needs. Professionals do integrated work and feel supported by their colleagues when they have to make difficult decisions. The most important thing is that people continue living in their homes and in their community. So people return or continue living in their homes, being cared by their families or other community services. Families learn other way of caring, and they have more time to organize the help they need. And in most cases, people recover their functional capacity. So that's all, and we can see a video that we can explain it a little bit more.
El proyecto de atención integrada social y sanitaria de Navarra se inició en el año 2018 aquí en la comarca de Tafalla, donde estamos. y luego se extendió en el año 2022 a las áreas de Estella y de Tudela. En este proyecto atendemos a personas que están en una situación social y sanitaria especialmente compleja y que necesitan una atención conjunta e integrada de profesionales de los sistemas de salud y de servicios sociales. En el proyecto se han creado unos equipos de trabajo, como es el equipo de coordinación sociosanitaria y equipos operativos de zona básica, formados por profesionales de ambos sistemas de salud y de servicios sociales. El modelo de atención que desarrollamos es el modelo de atención centrado en la persona. Lo que pretendemos es que las personas mejoren su calidad de vida, recuperen su capacidad funcional o la mantengan y que sigan viviendo en sus casas el mayor tiempo posible, o sea, que elijan dónde quieren vivir, prevenir las institucionalizaciones tempranas y, bueno, en definitiva, vivir en su entorno y en su comunidad. Para ello trabajamos, por supuesto, con la participación de la propia persona, de la familia y de su entorno comunitario, y desarrollamos también acciones comunitarias como, por ejemplo, promoción del voluntariado para el abordaje de la soledad, que facilitan que estos objetivos se puedan cumplir, ¿no? En definitiva, que las personas sigan viviendo en sus casas el tiempo que sea posible. Para poder aplicar este modelo de atención a las profesionales que estamos trabajando en este proyecto, hemos recibido una formación en atención centrada en la persona, gestión de caso, acciones comunitarias, y también hemos recibido por parte del Instituto de Salud Pública y Laboral de Navarra una formación específica para las personas cuidadoras de personas en situación de dependencia.
Me fracturé la cadera y tuve que ir al hospital. Y allí me mandaron a este servicio a reponerme. Y la verdad, pues ha sido mucho, de fisios, de limpieza, de cariño y de todo. Me ha gustado mucho ese servicio y la verdad, pues ha quedado ahora una amistad con todas las chicas que para qué. Gracias a este servicio pude volver a casa mejor, muy recuperada.
Thank you very much. I think this was a very interesting example of how you manage three parallel dimensions. One is actually better service provision, also that individual healthcare professionals feel less isolated, maybe more satisfaction in their daily activities. Maybe the doctors are more available to do clinical work. Maybe you can say a bit more about that. And that you're basically rethinking the whole organization in a more patient-centered way. My question would be, this seems like a very impressive good practice, but what were the main obstacles getting there? Shifting from a more institution-centered to a patient-centered model in these areas, what would you describe as the main hurdles, the main obstacles you had to overcome to make this work? Could you say a few words about how you made it actually function?
Yeah, it's not easy because system care is organized from the services. So now we need to focus on person. So the system has to change and has to be adapted. The result of that is to give people back the spotlight of their own lives. And people and families are the most important thing here. And system and professional must respect their decisions and help them in a difficult moments, but without forgetting they are who decide.
I'm sorry, I didn't get, they are
who decide about their lives.
They have the decision, yes.
Yeah.
Would you say that then with the system that individual doctors in these areas have more time to do clinical work, that help them, making them more available, as you have these persons, if I understand correctly, that coordinate a bit all the needs and identify, does that help the doctors focus on the patients more?
I think professionals do integrated work and feel supported by their colleagues in most cases when they need to make difficult decisions. So work integrated is difficult and they need time to do it. But in a long time is useful because people receive customized attention.
Veronika, I don't know if you have any reflections looking at this. What are your reflections around what you see?
I think it's a very impressive program. I think it's definitely focusing on that patient-centeredness and trying to integrate the different services, which from a clinician perspective, the way that I would see it is it means that I have somewhere to refer my patient to. So if I'm speaking to someone who's, let's say, had a fall and has come back from the hospital and wants to recover in their own community and not have to be sent somewhere else because they can't take care of themselves. If I don't have those services, if I don't have that physio that I can call and say, you know, this person has come home, could you please visit them? If I don't have that support for cleaning and other things that might need doing. So, you know, if the person can't cook for themselves, if there's sometimes community members will step into these roles in different rural communities, but if that's not there, which is often the case now as rural areas depopulate, then those people can't stay in their homes. And I think one of the main things that helps them recover is that ability to stay within their own community, to have contact with the people that they know, to be in that familiar environment, which is particularly important for elderly people. And the outcomes have been shown to be better if you enable that kind of community recovery and rehabilitation. And often the opportunity to do that is not available to rural people. So I think these kind of programs are really important, and hopefully there'll be more of them in the future.
Thank you. I think we will then move on to our next speaker, Juliette, who will present the Tel-e-dent solution, more specific, maybe technical, or not only technical, but a solution on solving a specific challenge, let's put it that way, in these rural areas of access to healthcare in home for elderly people, which I think also tells many stories about specificities, challenges in the rural areas, how actually you get intersections of challenges, healthcare challenges with particularly vulnerable populations that happen to be in rural areas, and how you deal with this combination of challenges to overcome this combination of challenges. Juliette, please.
Good morning, everyone. Can you see my slides?
Yes, very well. Thank you.
Okay, perfect. Well, thank you to the Policy Learning Platform for giving us the opportunity to present Tel-e-dent, which is a good practice from the Nouvelle-Aquitaine region in France. So my name is Juliette, and I'm European Project Officer at the Gérontopôle Nouvelle-Aquitaine. I've prepared this presentation with Dr. Alain Kirou from the Hospital of Guéret, who is also attending this webinar. And hello also to all the CARES partners. We are also attending this webinar. So I'm going to introduce my presentation with a few words about Nouvelle-Aquitaine, which you can see on the map. So the Nouvelle-Aquitaine region is a region of great spatial contrasts, where population with very varied socioeconomic characteristics coexist. First of all, it's an aging region, as you can see with the figures. Of its 6 million inhabitants, 24% were aged 65 or over in 2020. And this trend is increasing over time. This region is also the largest region in France, and it's also the third most rural, and half the population lives in a rural municipality. So to meet these challenges, the Gérontopôle Nouvelle-Aquitaine acts as a center of expertise, support, and action for active and healthy aging in the region. It's a public interest group whose founding members are the Regional Health Agency and the Nouvelle-Aquitaine region. It brings together all the stakeholders involved in active and healthy aging in the region, which you can see on the slide. We represent more than 250 members and also a scientific committee. It's like a collaborative approach that relies on 6 expertise departments, including Europe. And we are partners in European projects, such as the Interreg Europe CARES project. So just a few words about the CARES project. So CARES is a 4-year project which aims to empower policies on telecare and telemedicine solutions for older people and people with disabilities. There are 8 partners in the project, which you can see on the map. And the Gérontopôle Nouvelle-Aquitaine is the associated partner. And the Nouvelle-Aquitaine region, no, the Gérontopôle Nouvelle-Aquitaine is a partner, and the region is an associated partner. And our targeted policy instrument is the Regional Health Roadmap 2023 and 2028. And the good practice I'm going to present you was presented to the CARES partners as part of the project. So here you can see Dr. Alain Quero. And after this short introduction, I'm going to focus now on Tel-e-dent good practice. So, oral health is a public health issue. It contributes to a person's general good health and quality of life. And the consequences of oral disease can also lead to pain, malnutrition, etc. There are significant disparities in oral health within the general population, and these are primarily linked to the fragility of individuals and social inequalities. Regarding the local context, the first department, which is a division of the Nouvelle-Aquitaine region, because Nouvelle-Aquitaine has 12 departments, as you can see on the map, is faced with an important shortage of healthcare. For example, there are only 36 dentists per 100,000 inhabitants in Creuse, compared with 66 in France. It's one of the most rural areas in France. And regarding to the social context, the oral health of nursing home residents is an identified but underestimated problem. The specificity is that their suffering is not expressed verbally, and oral health needs are greater. They may require specific care, have cognitive disorders, or be uncooperative or even opposed to dental care. It's also difficult for these patients to travel, and there is a lack of suitable equipment. To meet these challenges, the Hospital of Guéret and Dr. Quero has developed the Tel-e-dent project. So what is it? What is Tel-e-dent? Tel-e-dent consists of assisted tele-expertise with the hospital to provide access to dental care to nursing home residents in rural areas since 2013. So Tel-e-dent is based on videos taken by nurses using a surgical endoscopic camera to examine the oral cavity of older people in institutions. So the videos are sent to the dental surgeon who analyze the video to establish a pre-diagnosis. So for who are the beneficiaries? So, well, as I said, the beneficiaries are older people with special needs, so with disabilities or cognitive issues, problems, or losing their independence. So here you can see the camera. One of the innovative aspects of Tel-e-dent is a choice to use a surgical endoscopic camera. As you can see, instead of a simple dental camera, while a simple camera will not be able to film, will only be able to film 2 or 3 teeth, and it's not suitable for non-cooperative people. The surgical endoscopic camera provides 120 degrees images with excellent resolution and the ability to zoom in. So now I'm going to show you the Tel-e-dent pathway with the 3 criteria, stages, and benefits. So the 3 criteria. 3 criteria are required prior to tele-expertise. The first one is an approved digital tool that ensures data confidentiality and cybersecurity. The second one is the validation of the process by an academic clinical research to ensure professionalism and legal and insurance protection. And the third one is a means to provide care after diagnosis and to have access to a dental surgeon. The first stage is the application. So application is submitted by carers, families, or trustees. A written information is sent to the applicant, and a written consent is given to the hospital. The stage number 2 is a video, as you can see. So the nurse trained in oral and dental telemedicine visits the establishment, collects the medical file, and takes a video of the oral cavity. The video and medical file are then sent via a secure messaging system. So this process follows a really precise protocol using high quality optical equipment and specially trained staff. And it complies of course with all regulations. And it allows the dental surgeon to focus on the diagnosis. And the last stage is the response. So when the dental surgeon receives the video, a pre-diagnosis is made. A treatment proposal is sent to the referring doctor, who informs the family and the patient. So the patient can choose to receive treatment at a clinic or in the dental department of the hospital of Gérontopôle. The benefits and evidence of success. So Tel-e-dent has 3 main benefits. The first one is the increase in healthcare provision, thanks to the delegation of tasks, time savings for practitioners. It improves also the territorial coverage. The second one is the improvement of the care pathway, thanks to the improvement of the patient approach with a trusting relationships. It's important to like the trusting relationships and a solution that adapts to patient with specific needs. And the third one, as you can see, is the economic gains, because it avoids costly travel and it optimizes the dental surgeon activity. Last year, they carried out 400 tele-expertise acts. They had a presence in 15 of the 31 nursing homes of the department, and they have a really good, like an excellent diagnostic performance. About the resources, the project is currently receiving operating funding from the Regional Health Agency, Nouvelle-Aquitaine. The Hospital of Guéret pays the staff salaries, and Tel-e-dent has received funding from the region in the past. About the human resources, you need, there are dental surgeon, nurses, coordinating doctor, and secretary staff. Well, you can see here the full-time equivalent if you're interested to know. And finally, about the next steps. Well, the first one is a gradual rollout to all nursing homes in Creuse. The second is a rollout in the department of Corrèze, which is another department in the Nouvelle-Aquitaine region, a rural department. New clinical research identical to Tel-e-dent, but on disabled people in institutions. And the last one is to set up a specific dental tele-expertise training for nurses. Thank you for your attention. And here you have a lot of links, etc. if you want to know more about this practice. And thank you for your attention.
Thank you very much, Juliette. I think this is an interesting case of how concretely technology is integrated into an organizational rethinking, using resources more efficiently, and arriving at that significant health benefits with, as you showed when showing the number of full-time equivalents, quite moderate uses of mobilization of resources with great effects. So this relationship between benefits and investment or resource use seems very, very beneficial. Once again, as we posted in the chat, you feel free to post questions you may have concretely on how this is organized. This is maybe my also general question of, did you feel any obstacle to be overcome? Are there any people that needed to be convinced? Were nurses happy to move on to take on this new responsibility? How does it work institutionally, the dialogue with all the actors that are still involved in making this work? Was that a smooth process, or did you see any specific issues to be overcome to make this function?
Well, it's really hard because it's working since 2013, but it's for the moment only in Creuse departments. So it could be more like in France or in the region, but yeah, there is a lack of funding from the regional health agency or other kind of public fundings, and yeah, it's difficult for them. Maybe also Dr. Keru, if he wants to respond by reaching, if he wants to add elements, he can write in the chat. But yeah, it's difficult for them, but they are really committed. To me, it's really a resilient, good practice. These are great people fighting till 10 years, and they are doing a great job. So we must put some lights on this kind of good practice.
Yeah, it also seems surprising that it didn't diffuse more. It seems like a practice that can help save money, because you can examine people maybe early, identify a problem before they have to be run to an emergency dental service with more costly treatments. So why do you think the diffusion and funding is still difficult? What are the obstacles? Who are not being convinced, or what mechanism prevent this from being diffused more in now more than 10 years of practice?
Well, I don't think I have the response to this question.
It's a difficult question.
Why? I don't know.
Okay, well, maybe today can also help to disseminate the idea, but at least the techniques and everything are available, if I understand. So the links we will now share also after the workshop. We will provide links if people are interested in getting more technical details of how this is done.
Yeah, of course.
Or maybe even having a direct contact with Dr. Keru for concrete questions on how.
He's really interesting in exchanging and talk about this good practice. So yeah, and I thought that Mart is trying to.
Yeah, I was curious because I also come from this SME background where you always work with startups and so on. I was wondering whether also in this case with the telemedicine solution for dental care, have you collaborated with some startups coming up with new solutions to make it even more easier to use this early screening, or is that something that you see that could be looked into to bring in this sort of private sector innovation component here as well?
Well, I'm going to respond instead of the doctor because he's the owner of the good practice. But the other actors or stakeholders that are doing this kind of things, they are doing it not in the wrong way, I can say, because it's not a surgical endoscopy camera that they are using, and I think that they didn't work with the private sector. Maybe you can correct me, but I really think it didn't. It's really a public, like a public good practice with public resources, the hospitals and the nursing homes, and yeah.
But do you see any obstacles to transposing it into a more private funding? You can imagine that it's more as a service, considering the resource use you mentioned. It could be imagined as some more service offer by, for example, nursing homes, and then run maybe through more SME type of models. Is that something that, or do you see any specific obstacles to transposing the operational model then to different contexts?
Well, I don't think there are many obstacles. Well, yeah. It's really hard to put this kind of issues because it's, as I said, it's really not common to talk about this kind of issues. It's estimated that 35 to 50% of people living in nursing home in France have dental or oral pathologies in France. But nobody is talking about this kind of issues, and it's like really invisible. Everyone has this kind of issues. A lot of older people, but nobody is talking about it. And there is also a lack in in training, like in dental training in France. Also, nobody is talking about this kind of issues. As Patricia said, it's important to have regional and national policies that support also telemedicine solutions, like our policy instrument in cares, like the health roadmap, because telemedicine solutions are really like it's really a key element to fight these kind of issues and challenges, and that's what we are talking about it also in the CARES project, as part of the CARES project, and yeah. But about the the private sector, yeah, it's difficult to because they also have a lack of resources in the private sector and in the public sector. I mean, for the nursing homes. So yeah, I hope I respond to
Thank you.
To this question.
Financing is often the key. I received a key issue. I received a question actually for the Navarra program as well from one of the participants on how are you financing the Navarra program on these coordination functions, maybe particularly. Do you have any information on how the funding models for this system, this reorganization that you have established?
For the beneficiaries, it's free. It doesn't have a financial cost. Our program is financed by the Government of Navarra.
But we don't know exactly the numbers because,
Okay, so it's basically the government decided that they want to put more money into the coordination of health services in the rural areas. Okay.
Yeah, all systems contribute with the economic part.
And has there yet been an evaluation of the program? Have they evaluated if this has helped saving costs in other end or creating a more effective or efficient health system? Is that
not yet?
Okay,
not yet.
So that would be in the pipeline then. Okay.
Yeah.
I just wanted to add that the service is free also for the nursing homes that are using this Tel-e-dent. Is also free. They only have to pay the transport.
Yeah, it's also free. The daycare center, the nursing home, and it's all free for the users.
Okay. Interesting. Once again, please feel free, the audience, to post any questions you may have about these good practices you've heard. I don't know if Veronika or Patricia have any reflections, if you want to just say a few words about what you've heard about and if it's inspiring you or resonating with your other observations.
Yeah, I think I just wanted to reflect on the financing of things. I think it's very important to remember that rural people are often kind of socioeconomically more disadvantaged. So anywhere where they're going to have to pay additional fees usually means that that's a barrier to accessing the service. So things like government-funded programs or programs that have been funded with no cost to the user are probably something we should be focusing on more for rural communities. And additionally, I wanted to reflect on what Juliette was saying about how underrepresented dental and oral health is in general within the healthcare system and the importance it has. It's definitely a very important part of primary healthcare, and I think sometimes that's not talked about enough. So I'm happy to see that there's a program like this happening in France, and it's a shame that it's not getting more traction. But it is definitely a good example of how telehealth can be used to integrate into other services within the health system. And I guess my question to Juliette is, what does happen with the transport, and is that providing a barrier for patients accessing perhaps further surgical procedures for their dental care?
Well, as part of the project, it depends because when the doctor is sending the protocol care, the patient can choose to go to a private clinical, or to the hospital of Guéret. And if the patient is going to the hospital of Guéret, the transport service is free. But if he wants to go to a clinical, he has to take in charge the transport. But otherwise, Tel-e-dent is free for the older people. This is sometimes a fear from families and patients the cost, because it's really expensive. Dental care, it's really expensive. But no, like it's free for this kind of, thanks to the regional health agency, Nouvelle-Aquitaine also.
Sorry, Patricia, maybe a few words and then Mart.
Thanks, Erik, and thanks a lot, Juliette and Inés, for the good practices presentation. I think they were very inspiring. I wanted just a few points I was writing down. For the financial aspect, for instance, in the case of Spain, health is universally free. Therefore, you normally access all these services for free. But I think that here, what it is important is to see how the system is articulated in a way that even if it is still public funding, it is more efficient in terms of really reaching out the patients or removing the barriers, so that there is also a prevention and not also a late treatment, let's say. So in any case, it's going to be, in the particular case of Spain, public funding, but then how efficient it is, not only for cost money, but also for the patient. For the case of the Tel-e-dent that Juliette presented, I like it a lot. The fact that telemedicine here is, and we highlighted this a lot in our webinar, is a tool. It's not replacing the professional. You still need, it's alleviating their work, it's removing the barriers in terms of mobility, in terms of number of people you need, but still is a very important tool. But there is a professional behind, there's people that are trained and so on. It's important to understand this, because some people, I think, are having the feeling that telemedicine will take over, and this is really not the case. And this also leads me to the point of the regulation. I think that normally public administration, there is this institutionalized system. Sometimes it's difficult to change mentality, to push for it, but we have seen in some member states how these particular cases become the spark to change regulations, how mobile units or how telemedicines were operating a bit of a gap system, and then they were pushing, and I can share an example of that, for instance, in Romania, that there was no regulation because of the work that rural doctors did. They ended up passing a regulation that was providing a framework to make this more accessible and also more trusted by the patient. Because if there is not the regulation, then why do you invest? They say there is a lack of investment and so on. Of course, you need a framework that is supporting this. And the last point for the case of Navarra, also something that I like it of this integrated approach, is also it's not only about health, but it's also mental health. And I think that you mentioned, for instance, or in the video, said the loneliness, and this is higher in rural areas, and this feeling of loneliness, especially for elderly. So this way of integrated way of treating the patients and having them decide and having them connected with the rest of the community, so that they don't have to leave their home, is very important for the loneliness and for this mental health, which is also very important of the overall health.
Thank you, Patricia. Before I pass on to Mart, I have one question from the audience to Juliette to close off. She was asking, or one of the participants is asking, how long was the training? How long is the training for nurses to do Tel-e-dent, to use this equipment and then the solution? And how easy is it to find nurses that actually have the time to do this? Because I imagine also nurses in these rural areas, many of them are very busy, so they may. How easy is it to find the people who want to add on some work to their pre-existing activities?
Well, for now, there is only one nurse who is doing this coordination and this job, and she learned like on the job. She learned really during the job with the Dr. Kebu. And that's why they're trying to do a specially trained like a training for nurses, like dental tele-assistance nurses, like because they are in France at least there is not this kind of training for nurses with a specialty in dental and oral health.
Good. Thank you. No, that's great. I think this is, once again, it shows us Veronika was saying you need to invent new roles somehow. This has to become a new role and something established, as if being a rural doctor in a way has to become it. You need to establish this as something specific and make it's a kind of factor of creating visibility of these roles that are important. Mart, sorry, now you've been asking for the.
No, I wanted to do the same thing to read out the audience question. So
okay, sorry. Okay, all good. Sorry. Perfect. But then I think we're closing. We're approaching the end of this workshop. I just a few messages that really struck me was how important it is for these work conditions for doctors in the good practice in Veronika's presentation, creating appropriate working conditions, having living environment for them that actually make this attractive. How important it is to think of more community-oriented solutions, bringing on the families, integrated models, that all of this is part of a functioning healthcare. And last but not least, the funding models adapted to the financial capacities of the target populations, and acknowledging the fact that rural healthcare is more expensive. It is, economies of scale are smaller, but this is a cost that somehow needs to be covered, and then so finding a solution to do that is key. So that would be my 3 key elements that I would take on from these discussions. There are many other very interesting and important elements, of course, but I try to summarize a little bit. I will pass on to Mart, just a few also closing. I don't know if you have also closing remarks, and before also presenting a bit how we can help continuing supporting efforts to find solutions in this field with the policy learning platform services. Mart, please.
My only closing word would be to thank the speakers for it was very insightful and the great discussion we had today. But indeed, as in the audience, we today also have people probably coming through the Rural Pact Support Office communication of the event, and I think it's good to say still a few more words about the policy learning platform and what we do here, so you would be aware of the services and support available through us. So basically, just as a context, Interreg Europe, it finances projects, as do a lot of these territorial programs. But in the case of Interreg Europe, the projects are all about policymaking, and you always have large consortia there. And you heard 2 good practices from 2 of the projects today. But in the sort of the second pillar of the program is the policy learning platform, where we try to provide further assistance to sort of make sure that the knowledge that's shared within a project doesn't remain in a silo of the project. So we try to build on it and bring added value. And then what we do with the platform is it's basically on the website of Interreg Europe, you find this knowledge hub of different policy briefs, reports. The good practices that were shared today are there, event recordings. And one of the things we do then are these events like this webinar to exchange our thoughts on a specific topic. And then we also have specific expert services that I will talk about very soon. We have a team of experts across Europe. You've seen some of these people here today in this session. And the expert services we offer are basically the help desk, the matchmakings, and the peer reviews. So whenever you have any policymaking question and you are seeking for some advice, you can use the policy help desks to send the question to us, and we will answer you based on the knowledge we have on our platform. But then the matchmakings and the peer reviews are tailored services for European public authorities for their particular policy challenge. So if you apply to one of these services, then basically we will give you tailored support to help find you answers for that. So differently from a workshop or a webinar where we discuss maybe a more general format, then you could come with a question of, how could we promote telemedicine in my region under the current conditions and structures we have in place. And then we, together with Erik and other colleagues, we try to find across Europe experts and examples who have done some maybe telemedicine, let's say, policies in regions. And then we come and discuss and try to give you this very concrete, tailored advice. And we've had these services around now for, over 4 years. 75 peer reviews have been implemented. And it's a 2-day format when they come on site, basically, to discuss with you these matters. And just as an example, for very soon in July, we're going to actually have one of these peer reviews on a health-related topic, which was also flagged today in the beginning, I think, with our speakers, that the shortage of healthcare professionals. So we're really going to go dig deep in the case of Centre Val de Llor, how we could solve this challenge in this specific region. And of course, rural areas is a big part of the Interreg community, and we've had different peer reviews tackling different aspects of the challenges that are present in rural areas. So if you're interested in these, you can find information about the services on our website. And of course, Erik and I are always happy to exchange with you and set up bilateral meetings to discuss in detail on how it actually works. Main thing is it's free of charge for public authorities, and it's a really simple application process. You don't compete with anybody, just an eligibility check. So I encourage you to look into it, because we are able to provide some good insights to you through these services. And thank you for your attention from my side. And back to you, Erik.
Thank you very much, Mart. Thank you also from my side to all the speakers, to the audience for questions and participation. I thought I think this was a very interesting exchange with many elements of that could be further inspire local and regional policies in the field. So thank you very much for all these contributions. A last point, we always try to make these workshops better. So there will be a last survey that will be submitted to you now in just a few seconds. We'd very much appreciate if you can take a few minutes to reply to this survey. This helps us making these workshops as useful and relevant as possible for all of you. So your inputs would be very much appreciated. So thank you again very much for these exchanges, and we look forward to seeing you again soon. Thanks.